So the correct diagnosis here is cochlear otosclerosis or otospongiosis. As many of you are aware, otosclerosis is also known as otospongiosis. They may sound a little bit contradictory to each other in terms of description, in that one appeared to be sclerotic, the other one appeared to be spongiform or lucent, but they represent a different timeline of the same disease process. So let's look at some of the imaging feature that makes otosclerosis or otospongiosis the best choice here, particularly the cochlear subtype, also known as retrofenestrial subtype. So what you're looking for is this abnormal lucency around the otic capsule in the inner ear. In this case, you can see there's a lucency that's surrounding the entire cochlea. As you recall on this normal patient, the otic capsule should be very dense. So anytime you see abnormal lucency surrounding the cochlea or around the anterior margin of the oval window, and you can find the oval window by the position of the crura of the stapes, that's where the foot plate is. So right at this margin, that's where otosclerosis or otospongiosis started. And that small focus may spray around the margin of the oval window and the round window, as well as extending around the otic capsule in this case, in our case, where you can develop into a abnormal lucency surrounding the entire cochlea, forming the cochlear subtype of the otosclerosis. Otosclerosis represents the chronic or sclerotic form of this disease process, whereas radiologists prefer the term otospongiosis in the more acute or subacute form, in that we can see the abnormal lucency on CT. Otherwise, it's very difficult to make the diagnosis of a sclerotic lesion on a dense bone. So otospongiosis is a preferred term for radiologists. As I mentioned earlier, there are two subtypes. One is fenestrial, the other one is, this case, cochlear form. In real life, fenestrial form is way more common than the cochlear form. But I think on board exam that will flip. You will likely see cochlear form more common than fenestrial form. The reason I say that is cochlear form is much easier to see than fenestrial form. So therefore, on the board exam, I think it's a little bit unfair to ask you to identify a small lucency right at the anterior margin of the oval window. So that's too much of an eye exam for a general board exam question. So I think on board exam, you're going to likely encounter this more extensive cochlear form. So on the normal anatomy, in this case, the oval window, again, you can identify by the crura of the stapes. Right at the anterior margin of the oval window, there's a small cochlear cliff that houses a fibrocollagenous tissue. That's called the fascicula antifenestrum. That is where otospongiosis started. So the fenestral form of the otospongiosis started right at this point, anterior margin of the oval window. In this example right here, this is a fenestral subtype. You can see this abnormal lucency right at the fenestrum. And in this case, this otospongiosis is also actually quite large. Often, in many cases, that the fenestral subtype is very, very subtle. So you should have a very high index suspicion. If clinically they are suspecting otospongiosis, make sure to inspect this region very carefully, looking for a small abnormal lucency. This is a nice diagram from STAR-DX. As you can see, as the otospongiosis start to grow from the fenestrum, it can start to go around the margin of the oval window and encroach into the oval window and causes fixation of the foot plate. Therefore, the most common presenting symptom for fenestrial otosclerosis is conductive hearing loss. On the other hand, for the cochlear subtype, you also the starting point is at the fenestrum, but you can spray and go around the entire otic capsule and go around forming this cochlear form or retrofenestrial form. And the most common presenting symptom for cochlear form of otosclerosis is sensory neural hearing loss or mixed hearing loss. So that may be a potential board exam question right there. So that's the cochlear form of the otosclerosis. Let's look at other choices that do not work as well in this particular exam. And we already talked about choice A is not the best answer here, just based on its appearance. For choice C, labyrinthitis cerficans, every year that we do board exam, when a resident come across a question about otospongiosis or otosclerosis, when he or she is asked for a differential diagnosis, and different disease process sometimes can be thrown out there. And one of the things that always got thrown out there is labyrinthitis ossificans as a differential diagnosis for otosclerosis or otospongiosis. And I think I understand why that's the case, because if you don't do a lot of head and neck radiology, sometimes a lot of these disease processes can sound similar. Otosclerosis, labyrinthitis ossificans, both are involving the bony labyrinth or in the labyrinthine structure, the inner ear structure. While clinically, labyrinthitis ossificans may be in the differential diagnosis for hearing loss, but radiographically, they should never be in the same differential diagnosis because they look exactly the polar opposite of each other on CT. So for otosclerosis or otospongiosis is that abnormal lucency surrounding the cochlea, whereas labyrinthitis ossificans is that abnormal density inside of the cochlea or inside of the inner ear structure. So completely opposite each other. Otospongiosis, abnormal lucency outside. Labyrinthitis ossificans, abnormal density inside. For large vestibular aqueduct syndrome, most commonly as part of the incomplete partition type 2, the most common congenital sensory neuron hearing loss cause, or at least imaging finding, is enlargement of the vestibular aqueduct. That seems to be a favorite written board exam question. In this case, though, we see the vestibular aqueduct is not enlarged. This is a good example of a bilateral large vestibular aqueduct syndrome in a 5-year-old with congenital sensory neural hearing loss. You can see that the vestibular aqueduct, which you can find that roughly parallel to the posterior semicircular canal. If this is greater than the posterior semicircular canal, it is probably too big. And in this case, it's definitely much bigger than the posterior semicircular canal. So this patient has a large vestibular aqueduct syndrome as a reason why he or she has a sensory neural hearing loss. And in our case, we certainly do not see an enlargement of that. So choice D is definitely not it. For osteogenesis imperfecta, and it is an imaging differential diagnosis for otosclerosis or otospongiosis. But for osteogenesis imperfecta, you can see abnormal lucency throughout the otic capsule, but usually they are a lot more extensive. You will see other temple bone structure or the calvarium shows osteopenia more diffusely rather than just locally or focally surrounding the cochlea or around the anterior margin of the oval window. So osteogenesis imperfecta is not the best choice in this case. That is all for this head and neck case number 6. Thank you for your attention and good luck on your board exam.